carrying on with our program, I would like to introduce you to our next speaker, Dr. Elaine Drysdale. Elaine has a BA in psychology, an MD degree, and is certified fellow of the Royal College of Physicists and Surgeons of Canada in psychiatry. She's a clinical professor of psychiatry in the Faculty of Medicine and University of British Columbia. She has worked as a psychiatrist for over 30 years in various medical settings, including over 25 years as a psychiatrist in the leukemia bone marrow transplant program of the British Columbia, in the BC Cancer Agency, and in the palliative care programs. She has spoken nationally and internationally regarding topics of psychiatry issues in cancer care, bone marrow transplantation, and near-death experiences. So please welcome me in joining Elaine Drysdale to the stage. Thank you.
Okay. Well, I'm so thrilled to be speaking here today, and I've been so impressed by the program. We had such a warm welcome by Dr. Sonia Doi, and I know that she would have loved to have been here in person. And we've had tremendous talks this morning. And I have been so impressed by the warm welcome of the Spiritist community as well. The hospitality is amazing. It's not like any other conference I've been to, so thank you. So I'm a psychiatrist I've done some research, but I'm mainly a clinician, and I've spent many years in the trenches, and that is where my talk originates from. So what I'm going to be talking about today are the aspects of spirituality, and psychiatry as I have experienced them in the trenches. And I hope that my talk is applicable to healthcare workers and also to the healers amongst you who are not in the professional healthcare system, because we can all be healing in different ways. And I want to talk briefly about how medicine has changed. In the early 1900s, it tended to be very biological, with bacteria was treated with an antibiotic, a broken leg was treated with a cast. And then around the 1970s and 80s, mind-body medicine became a little bit more prominent, and how the mind affected the body and vice versa. And so there were programs of biofeedback and programs of looking at the psychological aspects of pain. And in the past 20 years or so, there has been a gradual increased awareness of non-local consciousness, or dual consciousness, or non-dual consciousness, and non-local consciousness, and looking at the spiritual factors, including near-death experiences and remote prayer. However, most of us working in the medical system are more than fully aware that currently most of medicine is in phase 2 in practical work. But we can all do our bit to gradually forge forwards into era 3. So, spiritual issues. I heard over lunchtime that one clinician here wanted to ask a spiritual question of her patient, and was told by an advisor, well, spirituality isn't really necessary. It's not even relevant to the care of this patient. So I guess my question is, is the issue necessary or relevant to question in medicine? Well, I'm going to tell you about one of my patients. She was an executive who was given a life-threatening diagnosis that required extensive medical treatment. She said to me afterwards, the spiritual and emotional aspects have been huge, huge, huge in my illness. Everything was affected, and I was absolutely overwhelmed by and constantly preoccupied with the fear of dying. So in the clinical care of this patient, is her fear of dying relevant? Absolutely. So how would you help this patient or friend with the fear of dying? So how do I incorporate spirituality in practice? Well, first of all, creating awareness of spirituality so the concept becomes habitual. In North America, we often talk about the biopsychosocial model of illness. But I believe that we should be using the term biopsychosocial spiritual to fully address the concern, the patient's issues. So when I'm teaching the residents, I talk about the biopsychosocial spiritual way of formulating the diagnosis and helping to understand the patient. Now, one thing that can be helpful is the HOPE model that was developed by psychiatrists to guide spiritual assessment in medicine. So I know you're not all in medicine, but you can still think of some of these questions to ask with friends or relatives in a way that's most comfortable for you. So the HOPE questions, the HOPE questionnaire uses the letters HOPE as reminders, and H stands for sources of hope, meaning, comfort, strength, peace, love, connection. O stands for organized religion. P stands for personal beliefs and practices of spirituality. And E stands for effects on medical care and end-of-life issues. So if you're thinking about asking a patient or a friend about hope, some of the questions you could ask are, what gives you internal strength and sustains you? What are your sources of hope and peace? Do your beliefs give you comfort and strength in dealing with life? If not, did they in the past? And if so, what changed? That's an interesting question to ask. O stands for organized religion. Are you part of an organized religion? How important is this to you? What aspects of your religion are helpful or not so helpful? Are you part of a religious or spiritual community? Does it help you? So that might mean a prayer group, for example. P, personal spirituality, beliefs, and practices. So I will ask a patient, do you have personal spiritual beliefs that are independent of organized religion? And what are they? And that's when I might hear that the person believes in reincarnation or out-of-body experiences or whatever. And I say, do you believe in God or a higher power? And what kind of relationship do you have with God? Do you have spiritual practices that are helpful, such as prayer, meditation, scripture reading, attending services, music? One person said, I'm very spiritual, and I said, and how is that? And he said, I love to go hiking. So I kind of thought he was more motivated by athletic pursuits, but for him it was spiritual. And I think communing with nature certainly can be. E stands for effects on medical care and end-of-life issues. So has your situation affected your ability to do the things that usually help you spiritually? Has it affected your relationship with God? That's a big one. People often feel angry at God at that point. Are you worried about any conflicts between your beliefs and your health situation or decisions? And that would be relevant for Jehovah's Witnesses who can't have or don't want to have blood transfusions, especially if they have leukemia. That can be an issue. Are there specific issues that I should know about in providing your medical care, such as diet restrictions? As a doctor or healthcare professional, is there anything I can do to help access resources that usually help you? And so sometimes I'll make a referral to the spiritual care department. Would it be helpful to speak to a chaplain or to your spiritual leader in the community? End of life. How do your beliefs affect the kind of medical care you would like me to provide over the next few days or weeks? For example, people who are non-religious might request termination of life. Sometimes people who are religious also request it, but less commonly. So I have noted that in my work, there are a lot of spiritual themes related to the end of life, such as fear of abandonment by God. They feel forsaken, or they feel angry. They feel isolated, There's fear of the unknown. There may be anger and fears about imminent death, in addition to grief about life ending. Sometimes we forget about all the losses that people are facing. We're more focused on the fear of the afterlife, but there's also a lot of grieving about leaving the planet. However, those questions can be very helpful, and particularly in an outpatient setting, but I work often on an inpatient unit, the leukemia unit, or on chemotherapy wards with the cancer patients. And the patient I'm seeing may be quite nauseated or in pain or dying, and I'm certainly not going to badger the person with a lot of questions. So sometimes I just cut to the chase and I say, do you believe in a spiritual realm? Do you believe in God or a higher power? Do you believe in an afterlife? So this is simple but useful to provide support, especially if the patient has a life-threatening illness. With leukemia, patients can be well one week and then suddenly very sick the next week, and they haven't had a chance to deal with issues of mortality. Sometimes they're very young, they're in their 20s, even teenagers, and suddenly they're faced with the prospect that they might die within the next few days or few weeks. So I feel it's always helpful to ask, do you believe in an afterlife? Do you believe in God? Because it gives me a foundation that I can have for connection with the patient and how to know what's going to be most helpful. And it sounds obvious, but these questions are often missed because they're considered to be too private. And health professionals sometimes don't know how to respond, so they don't want to go near that area. But you don't need to be a chaplain to ask. We can all ask that. We can ask that of friends who may be facing a life-threatening situation. Now, I have found that it's very interesting that the assessment of mood and thought content, or what a person's thinking, can overlap with religious faith. Symptoms of depression can include feeling guilty, sometimes a very increased sense of general guilt, or it might be guilt about a specific thing. One patient of mine actually felt so guilty on the leukemia ward that he tried to commit suicide. He wasn't my patient until after he tried that, I might add. And I asked him why he felt so guilty. He said, well, there was an arson in the community, and I think maybe I'm responsible for that arson. I said, how can you be responsible? It happened last night. You saw it on the news last night. And he said, well, I was very rude irritable with one of the nurses, and she's such a young nurse, and maybe I was overbearing, and she probably was upset, and she may have been so upset that she went out and set fire to a building that I saw on the news last night. So that would be the extreme form of guilt, which I would call a guilty delusion. On the other hand, it might be very slight, that I'm feeling guilty that I didn't say thank you to somebody. Symptoms of depression can also include feelings of being punished, and that might be very slight, or punished or persecuted or rejected. It might be very slight, like someone saying, oh, I wasn't invited to that party. Maybe I'm not included. Maybe they don't like me. Or it might be something very extreme and delusional. Self-esteem can be lowered in symptoms of depression. I also think that loss of faith is a symptom of depression. We know that mood symptoms are mediated by the neurotransmitter functioning of chemicals going from one nerve cell to another. And it's my belief that somehow when people are depressed and they develop these symptoms, that they can lose their faith. And I actually experienced this myself when I was very exhausted and stressed as an intern and I prayed at one point, and it was the weirdest feeling. It just felt like a sense of emptiness, or it felt like thud, that there was nothing out there in the universe. And after 2 weeks, I'd had a little more sleep and a little bit of a break away, and I felt much better. And then I prayed, and I can't tell you exactly what was different, but it just felt more real or felt more appropriate. And I realized that when I was tired and exhausted, that there was an emptiness there. On the other hand, when people are manic, the opposite of depressed, they're going really fast, moving fast, talking fast, thinking fast, and things get bigger and bigger and grander. People can become hyper-religious with increased intensity and zeal. So it's interesting, in a lot of the studies since the 1980s, they've looked at, well, how does faith affect illness? How does faith affect mood? And they say, well, if you're depressed, you're not going to do as well physically, or it might make you, the idea is that you've got to increase your faith, and that will help your mood. But we rarely think, well, maybe the mood also can be improved, and that will help a person's faith. And it's a different way of looking at it. It's actually much more circular, I think. And this role of mood may be missed when viewed from a religious perspective. I used to have a practice of seeing spouses of reverends and ministers from various Christian denominations. And they had a lot of problem because they would get depressed, and then they would feel they weren't spiritual enough and that they weren't praying the right way, and or that they needed to pray more, and then there would be all the guilt that they weren't spiritually adequate. They should be joyful. And I recognized that they had depression, a lot of these spouses, and when they were treated for their depression in whatever way was appropriate, whether it was psychotherapy and antidepressants or whatever, then they felt much better. They felt that they were no longer spiritually inadequate. So I think it's important to stress that when you're talking to other people in religious communities. Okay. I'm having a little trouble with this. It's not moving forward. I'm not sure if it's locked. Maybe I just need to use this one.
There we go.
Oh, I'm not sure.
Yeah, just that one there.
Okay, so when I'm looking at someone on the bed in front of me, I'm thinking, okay, what makes this person at risk? What are some of the factors? Biological, psych, social, spiritual? What are some of the triggering factors, or why now? Biological, psych, social, and spiritual. What are some of the perpetuating or aggravating factors that may be biological, psychological, social, and spiritual? And what are some of the protective factors or helpful factors? So, as I mentioned, I've had a lot of experience with individuals and in group therapy, or in the trenches. A lot of it was in group therapy with cancer patients. Many had primary breast cancer, more had metastatic breast cancer, and I've been on the palliative care ward and in hospices with terminally ill patients, and also on the leukemia ward. So some of the predisposing factors are people can feel vaccinated against religion if they've been exposed to too much meaningless ritual in their early years. Sometimes they haven't had enough exposure, or they had wishy-washy exposure, and so they feel negatively about religious issues. They avoid funerals, they're unaware of resources. There may be family hostility to religion and lack of family teaching of forgiveness, and so they've been raised in a get-even mentality. So they're not going to be as spiritually oriented. They may have had a punitive father, and so when they think about God, they think that God is also going to be very punishing. And sometimes there's just a paucity of resources or spiritual or psychological mindedness. There's a paucity of inner resources to help them cope, and there may be a lack of spiritual or psychological mindedness in the family. What are some of the factors that are associated with getting sick? Sometimes these are triggering factors. Sometimes it's because of the illness. There may be loss of meaning in life, or asking, why me? Why am I sick? I've been a good person. They may feel abandoned by God or angry at God. And therefore they may avoid their usual spiritual practices. They may feel punished, generally, or for a specific sin. Depression may intensify feelings of worthlessness or the perception of being punished. There may be theological differences with others. I was asked to see one fellow on the ward because he said, well, I'm anxious. And I said, why are you anxious? He said, well, my friends want to pray for me, and I'm wondering if they should. So I thought that was an interesting problem to be anxious about. And I said, is that a worry? And he said, well, my wife figures that if I get better because of their prayer, then her support wasn't adequate, wasn't good enough. And if I get sick after it, then the kids will lose their faith. So it was an interesting dilemma about whether he should have prayer. I told him a little bit about the studies of remote prayer that had been done and how that had been shown to be helpful. And we together addressed some of the family issues which were really at the core of the question. The other fears about dying, sudden confrontation with mortality. I had one person in his 40s say, well, I've never thought about dying, have you? And I was kind of shocked about that because I thought everybody had. Actually, my grandfather had been a coroner and who was called to investigate any unexpected deaths, murders, suicides, or accidents. And so we'd be having dinner on a Sunday evening and he'd be called out and we'd wait for him to come back from the investigation, and then we'd have dessert. And I thought, wow, life is very fragile between the roast beef and the dessert. and by the time I was age 12, I thought, wow, I'm still here. But I knew that life was extremely fragile. So I felt it was quite amazing that someone in their 40s had never had to deal with the concept of mortality. There may be anxiety about questioning an afterlife. Sometimes patients are afraid of judgment or punishment in hell, or afraid of leaving loved ones. There may be fear of separation from loved ones after death due to differing beliefs, such as my patient who was evangelical Christian and was afraid she wouldn't see her husband after she died. And she went to her pastor, who said, your husband doesn't believe the way you do? You're right, you won't see him. So she went to her GP and her family physician, and he felt a bit overwhelmed and pressed for time, and so he didn't want to tackle the issue, so she was referred to me. So we had to deal with looking outside the box, and if she could love her husband, then perhaps God could love her husband. And we did discuss near-death experiences, and I will talk a little bit more about that tomorrow, about my patient. There are also fears of being forgotten or replaced after death. And sometimes that's not really addressed, but it's really present for a lot of people. I found that in my groups with women with breast cancer. There may be spiritual factors that are perpetuating, such as unresolved faith issues or discomfort or hostility to spirituality, and so they can't access the resources. People may feel uncomfortable about the topic of death, and so they avoid the topic and any encounters such as going to funerals, and they may decline potential help. Sometimes I've said, would you like a visit from spiritual care? No. And they may have a pre-existing phobia to the topic of death. I had one patient who had been phobic about dying since she was an young child. And she then developed leukemia in her 20s. And she had avoided anything to do with dying. She'd never watched a movie that had anybody dying in it. She'd never gone to a funeral or talked about it. I mean, she was really phobic. And now she had leukemia, and she was not doing well with the treatment. And I tried with teaching her about near-death experiences. I tried seeing if she would watch a video about near-death experiences. And I just couldn't make any headway really with her. She was admitted to palliative care, And the day before she died, she said, "See that cute nurse down the hall? I'm going to date him when I'm out of here." So she was in real denial about dying. I'd done what I could, and I thought a lot about it, and I realized this was the way that she was coping. It's not necessarily a recommended way of coping, but that's how she coped. And I felt at that point to tear off the denial would be like tearing off a scab. Because, you know, a scab is where develops when there's trauma to a skin, and when there's healing underneath, the scab falls off. And I thought, I think denial is like that, as a psychological defense. It's there to protect the person, and if we rip it off prematurely, then I think we can sometimes do damage. We have to respect her coping style. So you may dispute that, whether that was the wisest, but I thought I should do no harm, and at that point, that was how she was coping. So that is how I operate or function in a conservative hospital on the leukemia wards. And that's how most of medicine is, that era 2 medicine that I talked about at the beginning. And that's how I deal with sort of the meat and potatoes issues of spirituality, the day-to-day things. But what about the more mystical spiritual experiences? What is the best way to open the dialogue about near-death experiences, out-of-body experiences, shared death experiences, other spiritually transformative experiences? Lauren Belge is an ICU doctor in the US, and she found that the best way was to say, did you experience anything unusual? You had a cardiac arrest, did you experience anything unusual during the time that the code was called? And then people are more likely to open up. However, I'm a psychiatrist. People are already leery about telling me about any visions because they think I can read their mind, and they don't want to be have their experiences discounted. So I say, well, did anything unusual happen? But before you tell me whether anything did, I wanted you to know that I know that people can hear or see things for many reasons, sometimes because the brain is ill, and sometimes for truly spiritual reasons. I certainly don't think that all visions, voices, or messages are a sign of illness. And it's very important that I say that, otherwise people will absolutely deny that they've had a vision or heard a voice from an angel or God. So in saying that to one patient, she said, well, as a matter of fact, because you have explained that, I'm going to tell you that the night before my transplant, an angel appeared at my bed. She was 10 feet tall, and she had incredibly detailed wings and with distinct feathers, and she was infused with light. I've never seen anything before. And she said, I didn't tell anybody about this. I haven't told anyone until now, other than my husband, because I didn't want them to discount it. She said, I actually drew a picture of her shortly after I was discharged from hospital. So she showed me the picture. I asked her if I could take a picture of it and show it in the lecture, and she was really pleased to be able to contribute in her way. So I think that that we can ask, but we have to be nuanced in the way we ask the question, and certainly psychiatrists do. I think that near-death experiences and other spiritual experiences offer a practical bridge from clinical phenomena to spiritual possibilities. So, and it's vital that healthcare providers acknowledge and understand the phenomena of near-death experiences so that we can provide the best patient care. But beyond that, acknowledging that the content of the near-death experience provides the bridge that many clinicians need to move towards the spiritual and to appreciate other spiritual experiences. Healthcare professionals and other interested people all of you, need to spread the word about near-death experience and its frequency. Near-death experiences are actually very common. They occur in 5% of the population. And you think, 5%? For example, in the United States, with a population of 300 million, that's 15 million people. Why haven't I heard about it? People say. Well, if you start asking around, you'll be surprised. In my own inner circle, I found that 2 of my closest friends have had near-death experiences. And believe it or not, someone in my immediate family had. I said, would you like to watch this video about near-death experiences? And he said, oh, I don't need to watch that. I've already had one of my own. I said, what are you talking about? I've been interested in this for 30 years, and you didn't mention this to me? He said, well, it's private. So I thought if my own sibling might not want to mention it, and I hope he doesn't watch this video at some point. Sorry. That you would be surprised how many people, friends and relatives, have had it, an experience. So why is it? So first of all, I'm going to talk a little bit, what is a near-death experience? Well, it's the profound psychological event that may occur to a person close to death, or who is not near death, but in a situation of physical or emotional crisis. Being in a life-threatening situation is not the same as a near-death experience. I've had people come up to me and say, I've had a near-death experience. I had pneumonia and I was very sick. And I said, did anything unusual happen? Oh no, I just was unconscious. So that was not a near-death experience. It was a life-threatening situation. So a near-death experience is the pattern of perceptions creating a recognizable overall event. And it includes transcendental and mystical elements. And it's a powerful event of consciousness. It is not mental illness. So a brief history of the near-death experience work is 1975, Dr. Raymond Moody, an MD who had a PhD in philosophy, heard 2 stories of people with near-death experiences. And he said, if I personally have heard 2 stories, they must be quite common. So he decided to interview or review cases of 150 people who had experienced these phenomena. And they fell into several groups. People who had cardiac arrests, people who were in illness or injury and came close to death, and the experiences of grieving family. And he decided to write a book about what people experienced. And in 1975, it was called Life After Life, and it sold over 30 million copies. It became a bestseller. It was featured in a Reader's Digest, which was a common magazine in North America, I think here in England. And once it was featured in Reader's Digest, a few months after it came out, it influenced the movie industry. There was a movie, All That Jazz, and there was a dream sequence of a near-death experience. And it began to change the worldview about dying. Now I'm talking obviously to people outside the Spiritist community, because you've all had this wisdom for much longer as a community. And what Raymond Moody found was that people who'd had cardiac arrests at the time had a sense of great peace and absence of pain. And then many floated out of their body or popped out of their body and watched events below them. And we know that individuals can often later accurately describe the events in the resuscitation room or describe conversations that were down hallways or in different cities. They may experience going through a tunnel of darkness at high speed until reaching a realm of radiant light at the end. Some people do not report a tunnel but rise suddenly into outer space and see the Earth as it would be seen by astronauts. Carl Jung had such an experience. The dying person will often be met by deceased friends or relatives who greet them. Oh my goodness, I only have a few minutes. Even when the near-death experience person had not known that the deceased friend had died. And they tend to glow with an inner light. It's interesting that they're always people who have died. They may be met by a being of light, and they have a life review. In the life review, they see their whole life from start to finish, and they not only see every single event, but they feel what the other person felt. Like if they were angry at someone, they feel the hurt or the pain that the other person felt. So it's a real lesson for people about the effects of their actions on others. They may have a realization that acts of love, even though very simple, are of the greatest value in one's life on earth. And they may be reluctant to return. They usually are reluctant to return, but they feel they have to for loved ones, or they're told they have no choice. So other elements can be intense emotions, heightened perceptions of intense colors. They may see beautiful landscapes. A number of people have reported seeing this mountain area with a lake. They may have a life knowledge of the nature of the universe, a sense of oneness, a sense of having knowledge of the future, and they may have a message regarding their own life's purpose. Some people only have one or two of the elements. They're similar across age and culture. Dr. Melvin Morse published Closer to the Light about children's experiences. A 10-month-old crawled up the tunnel. One child thought that the being of light was Santa Claus. Near-death experiences are similar in individuals regardless of age, gender, education, and religion. They occur in people who were formerly agnostics and atheists, although they tend not to stay that way. Subsequent research has evolved and pushed forward the understanding of near-death experiences by some of the individuals on the screen. I'm just going to zip through this, but they come from different backgrounds in medicine and psychology. An association called the International Association of Near-Death Studies, or IANS, has an annual conference, which some of you may find very interesting, and it has encouraged research in the area. So there are various biological theories for it. People will often say, oh, it's delirium, or it's psychosis, or it's you didn't have enough oxygen to the brain, you had an infection, or a temporal lobe seizure. And so they're very different from delirium. And basically, delirium, people are very muddled in their thinking. Their attention is reduced. It fluctuates. Their thinking is very fragmented and muddled, whereas in near-death experiences, they're very clear and coherent. They may be quite agitated when they're delirious. And delirium is often marked by impairment in sleep with reversal of a sleep-wake cycle. And people's emotions in a delirium may be very changeable. They may go from irritable to angry to to being paranoid. And so these are very different from near-death experiences. So I'm just going to whip over a little bit because basically I want to say that delirium is very different from a near-death experience. And in delirium, there's usually a cause, either many multifactorial thing, kind of hypoxia or infection, plus medication side effects from morphine. Near-death experiences, we can't explain what would cause all these features. We can explain maybe why they had a near-death experience, that they were so ill, but we can't say what caused all the phenomena of it. What's also interesting is that some of these same features can occur with impending trauma when a person hasn't even been ill, such as observing an accident from out of body. And there can be similar features in dreams of the dying. So in those cases, we're not dealing with hypoxia or sepsis, perhaps, but it's a dream. So there are a lot of features that cannot be explained biologically. The course is very different. Delirium fluctuates over time. And a near-death experience is all or nothing. I'm sorry, I'm going to zip through these. The thought content is very different in delirium because they tend to be experiences where people are very frightened and they're very muddled. Someone thought that he knew me from a bank heist we'd done together, he said. People are fearful. They're never inspirational. I've never heard a patient say, I'm inspired to change my life because of my delirium. Whereas a near-death experience, the content tends to be reassuring, hopeful, inspiration, and people will change their values. And memory. Delirious patients don't have very poor recall of the events or what they were saying or talking about, whereas near-death experiences, people have excellent memory for details of the experience, and the memories last over time. There's a lack of decay of that memory. They'll tell you years later. The after effects of delirium, little impact. It was a nightmare. I don't want to go through that again. The after effects of a near-death experience people are more philosophical. They're less fearful about dying. Greater desire to be loving. Sometimes there can be both. And there may be a delirium interspersed with an actual near-death experience. And I think Dr. Eben Alexander, who is a neurosurgeon who wrote about his experience, had a delirium after his near-death experience. So there are various explanations, as I mentioned, but none of them explain all the facets of a near-death experience. For example, stimulation of the right temporal lobe can create an experience partially like a near-death experience with feelings of love and expansiveness, but it doesn't explain all facets of the near-death experience, such as new knowledge that the person gained when they were having their near-death experience, or their knowledge about distant geographical events or about future events. So I think I'm going, do I have to wrap it up right now, or I've got 5 minutes. Okay, so some people think that temporal lobe stimulation can have some of these aspects. And I heard one neurologist on the radio nationally in Canada saying, well, it's just the activity of the temporal lobe that explains it all, because you can put a probe there and get some of those same symptoms or features. And I thought, oh, for Pete's sake, if you can get that by stimulating that area, perhaps that's what that area of the brain is meant to be used for, to be accessing spiritual energy. And I think that the visual system is hardwired to perceive and process a certain range of light frequencies. But you can stimulate that area and have visual hallucinations, but it doesn't mean that true vision doesn't exist. And you can stimulate the auditory system and have auditory hallucinations. But the purpose, really, of the auditory system is to perceive sound energy, the energy that exists. So I think that the fact that the right temporal lobe, when stimulated, can produce some of these features, doesn't negate its role, but points to the true purpose of the right temporal lobe, which is possibly to perceive and process spiritual energy. And furthermore, if it needs to be perceived and processed, then this suggests the presence of an underlying spiritual realm. By the way, this is how morphine was discovered, and endorphins were discovered, because the scientists found that there were receptors for morphine. So if there were receptors for morphine, then maybe the body had its own endogenous morphine that it created itself. And that's true. That's how we found out about endorphins, because there were receptors. And similarly, if we can get these phenomena in stimulating parts of the brain, then that points out that that's what the brain is hardwired to do. That's what it's there for. So I'm going to skip over DMT. And what can't be explained by the biological theories? Well, there are 9 lines of evidence, as discussed by Dr. Jeffrey Long in his book, Evidence of the Afterlife. The 9 lines of evidence must be taken together. And the first one is that when people have a near-death experience, their alertness and consciousness is usually greater than that in everyday life, even though the person is medically unconscious. And so that factor alone is the major one. But the near-death experiencer might see and hear events that are later validated by others. This is called a veridical perception. That was an experience that was verified. And we can't explain. How can someone who's unconscious be aware of conversations in a different city, word for word, or events that occurred in minute detail that were later verified? Some people who've had experiences were blind or born blind, and yet when they had their near-death experience, they had normal or supernormal vision. We know that near-death experiences can occur under monitored general anesthesia at a time when conscious experience should be impossible. We know that in life reviews, they include real events that may have been forgotten or previously unknown by the person who had the experience. So they can actually learn new information during their unconscious state that they didn't know prior. So when you start taking these all together, it discounts any single biological theory of trying to interpret why a near-death experience occurred. Furthermore, people, when they encounter beings on the other side, they're always deceased, and you'd think that if it was something from their current life that they would have visions of somebody from their current life who's alive, but that does not occur. Children's experiences are very similar, and these experiences are similar around the world and despite different cultures and different religions. The after effects are often powerful and lasting and follow a consistent pattern. So when you take all these lines of evidence together, there is no single biological theory. Hypoxia, sepsis, temporal lobe stimulation, there's no single thing that explains it. And Dr. Eben Alexander wrote, I'll just summarize that, he said, like many other scientific skeptics, I refuse to even review the data. And those who assert that there's no evidence for phenomena of extended consciousness believe they know the truth without needing to look at the facts. But he said, the event that was most convincing to a skeptic was to have an experience. I think that's true. So I think it's time for me to finish. I'm going to include the next little bit in my talk tomorrow about why we can't see it, the spiritual realm, or maybe address some of it in questions. Okay, thank you very much for your attention.